It's the AEMT lecture series. This will be video number 1 for chapter number 12, Pharmacology. I'm back, and I appreciate all the well wishes that I received from folks in our class, and also people here in training. Made me feel missed, and I appreciate that. It's a long road, but I'm back and I'm excited. So let's talk about pharmacology because there is a lot to talk about. We're going to introduce you to pharmacology in this chapter. When we're talking about pharmacology, we're talking about the study of properties and effects of drugs and medications, right? But and this chapter is full of definitions, okay? So we'll identify those definitions as well. When we're talking about drugs, right, we're talking about a chemical agent that's used in the diagnosis and talking about treatment, maybe prevention of disease. Okay. Drugs are let's see. No, that's all I have on that too. So same as the slide. And then when we talk about medications, we're talking about more of the chemical substance, right, that's used to prevent disease. So drugs, we're talking about chemical agents, and medications, a chemical substance. I think you could call the difference here is we might have more than one chemical agent in a drug, but usually when we're talking about the medication, that's like just usually a single substance. Okay. The terms drugs and medications, we know they're often used interchangeably. Drugs may make some people think of illegal substances. So we should try to use the word medication when we're talking about, hey, we're going to give you some medication to make you feel better. So we're going to give you some drugs to make you feel better. So it's just it's all about terminology, right? And yeah. Okay, let's go to the next slide. Again, dose. All right, the dose is the amount, of course, that's going to be given. But then there's an action that we're looking for. All right. We hopefully get a therapeutic or intended effect of the medication. But you'll soon find out that even though we're getting a therapeutic response, a lot of times we get a lot of side effects that we may not have expected or didn't anticipate. So we always have to have that in the back of our mind. But we are looking for that therapeutic or intended response of the medication. And then when we're talking also about medications and responses, we have unintended effects. Okay, unintended effects. All right, and these are something that's going to be maybe undesirable. Okay, but they pose little risk to the patient. And then we'll compare that with untoward effects, right? These can be harmful to a patient. Then we have toxicity, okay? And that's a risk of the substance actually bringing harm onto the individual. Indications. So when we're talking about indications, the therapeutic use for a particular medication. And then contraindications. Excuse me. Contraindications is a time when you should not give a patient a medication, even if it's usually indicated for that person's condition. we would say, you know, maybe in a certain case, the patient's allergic to morphine. We would not want to give morphine, even though it meets all the indications, to be contraindicated for that patient. All right. So when we talk about medication names, right? Catch up. I got made some notes from the chapter. I want to make sure I'm hitting along the way. All right, here we go. So yeah, so we have they're derived from 4 principal sources. Okay. Animals, vegetable, minerals, and synthetic compounds. All right, so insulin, if we use that as an example, is usually prepared from the pancreas of an animal. Okay, and so what they do is they make like a synthetic of that. And then like vegetables would be plant sources, like roots, leaves of flowers, seeds, minerals. Okay, then you have in the minerals section, we can talk about like calcium. We can talk about iron. We can talk about magnesium. And then synthetic compounds, you could think about like synthetic forms of like vitamins, steroids, narcotics, usually even insulin can be a synthetic sometimes. I think don't quote me on the insulin thing. I'm pretty sure I'm right, but I might not be right. But you get the gist of it. You get the gist of it. Hope everybody's having a good day out there today. Let's talk about this though. So, because this is confusing, and this comes up on test. This comes up not just on our test, but you'll see it at registry. And so let's get it down pat now, so it's not an issue, right? So a trade name. When we talk about a trade name, we're talking about a brand name that a manufacturer gives a medication. Okay, so let's use, for example, Tylenol or Lasix. Okay, trade name. Then we talk about the generic name. Okay, so generic, usually its original chemical name, and we'll get to that in a second, but it's usually the case. Now, if you're writing this stuff or whatever, like in a report, you're typing a report, generally we don't capitalize a generic name. Okay, it's usually not capitalized. The generic is usually suggested by the first manufacturer. That's where the name comes from. And it has to be approved by the FDA. Okay. Sometimes the generic name is called by its generic name more than the trade name. Like nitroglycerin. Nitro is a generic name. The trade name for nitroglycerin is Isordil, I think it's it. Yeah. Let's see. Yeah, Isordil. So anyway, we never call nitro that, right? We just call it nitro. Then we have the chemical name. And so the chemical name is the precise description of the chemical composition and molecular structure that makes up that drug. So that's the chemical name, and that can be like all over the place. Like number 3, trying to think of a chemical name. Like anyway, I'll come up with one maybe later, but that's the chemical name. Then you have the official name. And the official name is assigned by the United States Pharmacopoeia, I think is how they say it, the USP. And That's that's the official name. And so the official name is usually the generic name followed by the USP. Okay, so let me think here. You could say, and what's an example of that? Would be the official name signed by the USP, usually the generic form, ranitidine USP. There you go. And ranitidine is Pepsid, I think. All right, so okay, here's a good example of a chemical name. We have number 9 chloro, 11 1721 trihydroxy, 16 methyl pregna, 14 diene, 320 dione, 1721 dipropionate. The generic version of that is called bechamthasone dipropionate. The trade name is Venceril. And the official name is bechamthasone dipropionate USP. So, continuing medication names. Prescription medications. These are obviously distributed by pharmacists according to a physician's order. Okay, so physician writes out your prescription to take hydrocodone 5. So you give your strength of your hydrocodone, and you take it. Maybe you take it once every 6 hours for pain. And then you have the over-the-counter medications. Now these are your all your Tylenols, your Motrins, your antacids. You can purchase those without a prescription. So sources of drug information. And here they are. You have the American Medical Association. You have the Physician Desk Reference, or PDR, hospital formulary, drug inserts, and internet. But the PDR is probably going to be your number one choice to look something up about a drug. And they update these Physician Desk References every so often. They try to keep them current. So, yep. Let's see here. So we talk about U.S. regulations of pharmaceuticals. Okay. So we have manufacture of pharmaceuticals is subject to a variety of laws and regulations. Imagine that, right? And it goes back a ways. So we can see here. One second though. But let's talk about what's the goal. What's the goal of all of these legislations and all of that? Well, the goals of the laws and regulations is to protect the consumer. Okay. And you're protecting the consumer from false claims. Okay. They prohibit the incorrect administration. So they may, instead of, maybe it benefits the manufacturer for you to take this as an injection rather than by mouth, and so it restricts them from doing that. allows it forces manufacturers to publish information about side effects and harmful effects of these drugs. And it also forces them to drugs that are produced by different manufacturers are make sure that they're uniform in their strength and their purity. So in the U.S., drug standards are published in the USP and the National Formulary. And then there's several federal laws enacted to protect patients from these unsafe substances and unscrupulous manufacturers and distributors. So it goes back to 1906 and protection of the public from foods, medications, and alcoholic beverages. Yeah, it stops them from mislabeling these things too, right? I mean, you can't say that this, and this probably goes back to what was going on in 1906. You had your traveling salesman coming by, trying to sell you, tonic, saying it was good for cough and made you live longer, stuff like that. They couldn't mislabel that. It stopped them from doing that. Also, it makes them be honest about is this poisonous or harmful? So yeah, it keeps them honest as as we can be. But so if we look at that the Pure Food and Drug Act of 1906 was the first federal legislation protecting the public from mislabeled items we just talked about. Then we can look at the Food, Drug, and Cosmetic Act of 1938. Okay, and we're having issues with labeling. All right, so they force now the manufacturers to label if the drug is habit forming. Is it a habit forming substance? And then they started making them list the side effects. And then they said, you know what, we need a government organization to monitor this. And so in 1938, part of that legislation was to create the FDA, the Food Drug Administration. They also mandated prescriptions. So that's when physicians had to start writing prescriptions, and it was limited to physicians, dentists, and vets. Then you have the Harrison Narcotic Act of 1914. So in 1914, they decide to regulate the import of certain medications coming in, the manufacturing, prescription, and sales of non-narcotic, also narcotic derivatives such as cocaine and opium. They said in 1914 that there needed to be better record keeping of these controlled drugs, and forced manufacturers to register if they were going to sell these types of drugs. Pharmacies then started getting into the game. Say, well, we need a place to issue these types of drugs out. And in 1914, they said we need some penalties, some fines, maybe even some jail time for people who continue to break the law. Then in 1956, the Narcotic Control Act, and what it basically did was increase those penalties of the Harrison Act, and said that the possession of heroin, just needs to be illegal altogether. And they also outlawed the acquisition and transportation of marijuana. Said no more. Can't have you guys making it and driving it up and down the road. Can't do it. So that is that. Pure Food and Drug Act we already talked about. I don't think I talked about all of that too, which is good. All right, we didn't talk about this yet. The Controlled Substance Act of 1970. Okay, so this was comprehensive. All right, this is kind of 1970, so we're tired of playing games. We got to have this spelled out to the letter so that we can enforce it. So it was comprehensive legislation dealing with narcotic and non-narcotic drugs that have potential for abuse. And so what does it specify? It specifies registration, procurement, how they're going to how it needs to be stored, and how it's going to be distributed. When they record keeping for these drugs, they were more specific on how that was going to be kept, and more specific about the penalties for failure to comply with the requirements. Let's see here. They also classified these controlled substances into five categories or schedules. And that's kind of how they're really looked at as schedules. This is a schedule 1 drug, 2 drug, 3 drug, 4 drug, or 5 drug. So let's see if we have some stuff to go over there. All right, so let's talk about that. I don't see a slide for it. All right, so scheduled 1 drugs. These are the highest abused habit-forming drugs. Okay, the highest abuse potential. Okay, for drug dependence. And they also have no accepted medical application. Now you'll notice that marijuana is one of those drugs. Now I know we've seen in the last few years that they're using parts of marijuana to treat for seizures in children and blah blah. But we still have it in the literature as being a scheduled 1 drug. So we're going to keep it there for now. LSD, which we know is a great medical drug, but not really. Not unless you like seeing snakes and stuff like that. But yeah, LSD and heroin. And I guess in its raw form. No medical purpose. So those are some examples of drugs that are high abuse potential. At least somebody said they're high abuse potential. I don't have, we don't have to agree, but that's what they say. So you see it on a test, we know what to put. Then if we look at the Schedule 2 drugs, so these also have a high abuse potential, but not as high as Scheduled 1. So we're going to go from Scheduled 1 to Scheduled 5, and every time we go like up, like Schedule 1, when we go up to Schedule 2, less potential for abuse. Okay, but still there. Still possibilities for sure. Still Schedule 2, still a high abuse potential. But it has a legitimate medical purpose. Like fentanyl. Okay, fentanyl. It's in our drug box. High abuse potential, but we know it has a medical purpose. What about cocaine? Cocaine, that song. Anyway, cocaine, right? Believe it or not, has a medical purpose. What they do is they use a little bit of cocaine and put it in a little paste. It's called tack. And at Eggleston, they have it there. So when a pediatric cuts, and it really works good for facial lacerations, we can put a little bit of that tack on there, and it does a couple of things. One, it constricts. It's a big vasoconstrictor, so it actually stops the bleeding, and it causes that area to go numb, so that your pediatric patient doesn't have to have lidocaine injected into that area, and it's, you know, so much better that way. So that's one reason why, if you have a kid and have a laceration, go to Eggleston or one of their clinics where they have that, because not all ERs have that, and it'll be easier on your kid. But hopefully you've learned by now that if you have a kid, you're not taking to Eggleston for any type of medical or trauma, then you're probably, you're wrong. You need to take those babies to where they can get the best help. The best help. All right. So that covers Schedule 2 drugs. Schedule 3. So we have a less of a potential than Schedule 2 and Schedule 1. And you'll find hydrocodone as a Schedule 3 drug, Vicodin as a Schedule 3 drug. And then moving to Schedule 4, you'll find your Valium and your Ativan. Okay, so less of a potential than hydrocodone, right? And then Schedule 5. A Schedule 5 drug would be a narcotic cough syrup. They'll take hydrocodone and put it in a cough syrup to help you to stop coughing. I just had some, as a matter of fact. And it works pretty good. And I'm not addicted to it. So, great. Federal legislation also looks at that dose of that drug and guarantees standardization of doses, right? And we talked about that a minute ago. So if I am Pepsid, right, and now, it's time to sell the generic of Pepsid, and we do like ranitidine or whatever, right? It keeps that dosage. I think it's 20 milligrams, but that 20 milligram tablet of Pepsid has to be sold as 20 milligrams of ranitidine. So that's one of the things it does. And so for it to carry that USP label, it has to be 95% to 105% of the standard on the label. Government regulation. So we have the FDA, Food and Drug Administration, the DEA, the Drug Enforcement Administration, PHS, the Public Health Service, and the Federal Trade Commission, or FTC. Some of that comprehensive legislation made all new drugs go through animal studies and clinical trials in humans before approval. And then we get into some clinical trials. So, phase 1 is a new drug that's being tested. We're going to test it in some healthy individuals that are going to volunteer to compare that human data with that animal data. And then phase 2, we're going to look at performed in a homogeneous population of patients. Phase 3 is going to take it to a larger group of patients. And phase 4 is going to go to be applied for FDA approval. And so storage and security, right? So we need to make sure, one, that the drugs are safe. That's why we have our drug boxes locked up in the engine or twin or ladder, right? So that, it stays safe. We have to keep up with some paperwork that's, we may go out and give Zofran, right? No special paperwork is needed for Zofran. Zofran, we dump a ton of Zofran in people, right? And You don't need anything special for that. But if we were to administer a controlled substance, it changes everything, because there's a separate piece of paper that's got to be filled out, right? And somebody, if it's our stuff that we've given, we got to go to the hospital and get a signature. So a little more paperwork, because we got to keep up with that stuff. Got to keep up with it. Like if you have an expired Zofran, they just throw that stuff away, man. That's what they do. They don't care. Dump it out, whatever. But if you have an expired vial of morphine, that doesn't get thrown away. That has to be accounted for. So there's some differences there. We have to make sure that when we're storing medications, that it's temperature consistent. And I know we don't do that, because the engine bay is probably 180 degrees. And inside the engine is the drug box, and add another 40 degrees to that probably. And so that's what you're looking at. But that high temperature does affect your drugs. It affects the potency of those drugs. We used to, back in the day when I started here, all the EMS units had temperature controlled drug cabinets. Then you have light. So drugs like nitroglycerin, or if they're exposed to light, it's going to mess up the potency of that nitro, and it's not going to work. Certain drugs are affected by moisture, shelf life, air exposure, etc. Pregnancy in patients. Whole list of stuff there. Whole list of stuff. So when we're talking about pregnant patients, or what we should be saying, not just pregnant patients, but females of childbearing age. Okay, that's what we should be talking about. Oh, I'm sorry, guys. Not sure what happened there. All right. So let me flip over to my notes here. Stand by. Okay. And let's talk about it for a second. So we're talking about females of childbearing age. All right, you get somebody who's sick, in general, going to require some medication. We need to make sure that the medication we're giving is not going to affect the fetus. So we ask the patient always, are you pregnant? Is there a possibility you could be pregnant? Right? And we have to go on their word. If come in, once they get to the hospital, they'll get tested for pregnancy, depending on their condition. If there's going to be some serious medications that's going to be given, and we'll talk about how we determine that, then we're going to get a pregnancy test, because the female of childbearing age may be pregnant and they don't know they're pregnant, even though they swear that they're not pregnant, and then they show up pregnant. But when we're giving medications, and this goes for anybody, we're looking for the benefit versus the risk. Okay, the benefit versus the risk. And when we're talking about the health of the woman is always going to be the priority. Okay, they're always going to be the priority. Example, years ago, I had a female patient who was almost full-term pregnant, and she was in VTAC. Her complaint was dizziness. I just happened to put her on the monitor, and she was in VTAC. I had to give a series of medications. Now, the medications had risk, but we'll talk about how we get into the risk of drug versus fetus. But the female patient, the woman, was the priority, and the risk of the drug were very minimal when we were looking at the benefits of her staying in a lethal rhythm and dying. So that's the kind of stuff we're talking about right now. There's a definition in the book called tetragenic drugs. These are drugs that pose a risk to the normal development or health of the unborn fetus. Tetragenic drugs. Okay. When we talk about drugs, we need to look at the metabolism of the drug. And the metabolism of the drug we look at that versus also the changes in a woman's body during pregnancy and how that drug's going to be metabolized by the liver during pregnancy. Okay. We have to look at also prescriptions and over-the-counter drugs that the patient could already be taking and how the drug we're going to give could affect the drugs that the patient's already taking. And then here at the bottom of the slide, you'll see that the FDA established categories to indicate drugs that cause problems during pregnancy. That's what we're going to talk about. So the FDA has a scale that goes A, B, C, D, and X. Okay. So let's talk about it. So the FDA scale, so if it's an A, it means studies have shown a remote chance of harm. Or studies have not demonstrated risk, or there's no studies, or their studies have shown an adverse effect that was not confirmed. I'm sorry. Let me start over, dude. Folks. Man, I am like going way ahead. Let's start over. All right, so again, FDA scale A, B, C, D, or X. When we talk about A, okay, so we're talking about studies show a remote chance of harm. Okay, there's a remote chance of harm. When we talk about B, the FDA scale B, studies have not demonstrated risk, or there's no studies. Okay, so B is have not demonstrated risk, or there's no studies. B could mean studies have shown an adverse effect that was not confirmed. Okay, so we have very little information in B. When we look at category C, category C states that animal studies have revealed an adverse effect. Okay, or there's no studies in women, or animal women studies available. All right, and so in that case, the drug should be given only if the potential benefit justifies the potential risk to the fetus. All right, so that's what I was talking about earlier. We're going to weigh out the benefit to justify the potential risk. So you have a pregnant female whose vital signs are stable. Their blood pressure is normal. Their pulse rate's normal. They're getting plenty of oxygen. Their lungs are clear. And they have something going on that you have a medication that will fix it. You probably need to hold on that drug because of the possible risk involved. Now, because we're in the pre-hospital care arena, we need to give medications that, save lives in this case, right? Right now, she's uncomfortable, right? She's uncomfortable, but she's stable. And so we can reevaluate that drug at the ER when we have time, what, to look it up, make sure everything's good, make sure it's appropriate drug, risk benefit, all that. Okay, so that's what I'm talking about. Now let's go to D. D is there's positive evidence of human fetal risk. The benefit may be acceptable to the risk, maybe. And then we're going to look at X. And X says there's animal or human studies that demonstrate fetal abnormalities, evidence of fetal risk. The risk of the use clearly outweighs any possible benefit. These are the drugs that are being contraindicated in women who are or may become pregnant. So X would be something that, we're not going to give it. It's already been determined that the risk does not outweigh the benefit. All right, let me see if there's anything here I need to cover. Oh, covered all of that. One second while I get caught up here. All right. Pediatric patients. So medications, of course, are going to have much different effects in adults and then in children. They're metabolized completely different. You have a smaller weight. Young infants, their metabolism's reduced, sharply reduced. Children can metabolize some medications more quickly than adults. So that's your differences in children and medications. What about geriatric patients? Same thing, right? Your geriatric patients. I don't know why this thing's acting up, but it is. Geriatric patients. Hepatic functions means liver functions, right? And their gastrointestinal activity are slower in older patients. That means that the liver metabolizes these drugs. They're going to metabolize it slower. And that could be a problem. Geriatric patients are often taking several medications. And there's a definition for that. It's called polypharmacy. Poly-many pharmaceuticals. Okay, so that's another problem with them. Yeah, and so a lot of these medications too with geriatric patients, like take a Benadryl, right? Benadryl for, non-geriatric patients make you a little sleepy, whatever. Benadryl metabolized completely different in older folks, and it could make them have a, really bad altered mental status. That's something to think about. Scope of practice, right? Do we remember this, right? Let me make it smaller here. Scope of practice. So Remember to administer the drugs that are inside your scope of practice, what you've been trained to administer. You know what? I'm not a field guide type medic. I don't want to be flipping through a field guide trying to figure out what drugs to give. So I don't want you guys to be field guide advanced EMTs either. We need to know these drugs. We'll go over them, but we need to know when we. There's nothing I can stand worse, really, is seeing somebody be indecisive about what medication to give. Know your drugs, know your dosages, know when they're indicated, when they're not, because this is what we do. Let's talk about how these drugs are classified. Go through that, because I think if you can figure out how drugs are classified, it does help understanding it. Oops, that wants to do something else. Hang on. Well, I still think you guys can see it. Oh, hang on. Maybe I can figure it out up here. There we go. All right, so drugs are classified based on the effect that they're going to have on a particular part of the body. Okay, so there's 3 categories: body system, class of agent, and mechanism of action. Classification of drugs are based on the effect the drug will have on a particular part of the body. Many medications fall into more than one category. All right, drugs or medications can be classified into these 3 categories. We talked about them: body system, and that means like the categorizing by the system affected by the drug, like nitroglycerin. Nitroglycerin is a potent vasodilator, right? And it's used for angina, and therefore it's a cardiac drug. Okay, and then understanding which systems are affected by which drugs. Class of agent. Class of agent tells how medication affects that system. So body system for nitroglycerin, cardiac. The class of agent, it's a potent vasodilator. Okay, and the mechanism of action. Our particular action by which the drug's created is a desired effect on that organism. So it dilates the coronary arteries. Nervous system classification. So let's talk about that. All right, so you have your, it's called autonomic pharmacology, right? And so remember you have your peripheral nervous system. All right, and in the peripheral nervous system, it contains the autonomic nervous system, okay? And remember the autonomic nervous system, okay, that controls what? Those involuntary functions, right? Those involuntary functions. All right, so it controls ANS. Remember then that your autonomic nervous system is divided into 2 different things. Okay, you got your sympathetic nervous system, which is your fight or flight. Just get on your horse and ride, right? Then you have your parasympathetic nervous system. And what the parasympathetic nervous system does, it slows everybody back down, right? After the danger's over, the parasympathetic says, hey, dude, you need to calm down. Okay, you're talking too loud. Calm down. So parasympathetic nervous system, right? It slows everything down. All right. Let me see what the next slide is. Okay. So, when we talk about the sympathetic nervous system, right? What's it do? Well, it releases adrenaline from your adrenal glands, right? And the sympathetic nervous system can also be called the adrenic nervous. Well, don't call it that, but the adrenic, right? And the effects on that, if we want to stimulate the sympathetic nervous system, okay, we're going to release epi and norepi, right? And what do we get out of that? Well, we're going to get that shunting of the blood from the extremities to the vital core organs. We're going to get an increased heart rate. We're going to get an increased respiratory rate. We're going to get an increased blood pressure. Pupils are going to dilate, and the digestive system is going to slow way down. So there's some cases where we need to do all of the above, right? If we have somebody who has a low blood pressure, a low pulse rate, then I want to use some drugs that's going to stimulate the sympathetic nervous system, right? And so we know epi and norepi are hormones. They're hormones that are released by the sympathetic nervous system, right? And the intended effects of those hormone receptors. What are I just said what the effects are. So when epi and norepi is released, it's a hormone, it's going to float around and it's going to go to those hormone receptors. And once those hormone receptors say, oh, let these, let them in. I am a hormone receptor and there is epi floating around, that's a hormone. There's norepi floating around, that's a hormone. Let me receive it. And once it receives it, its effect then is everything I just said: the shunting of the blood, the increased heart rate, the increased respiratory rate, increased blood pressure, pupils dilate, and the digestive system slows way down. Okay, those hormone receptors are called adrenic receptors, and they cause a response in that target organ. And we already know this. We already know alpha 1, alpha 2, beta 1, beta 2. We know how that works. We know that alpha 1, we're going to get peripheral vasoconstriction from alpha 1, right? We know in alpha 2, we're going to get peripheral vasodilation and little to no bronchial constriction, right? Remember, beta 1. Okay, beta 1, how many hearts do you have? 1. You have 1 heart. Beta 1, 1 heart. Increase heart rate, increase automaticity, right? It's going to increase those cells to fire. It's going to increase cardiac contractility, and it's going to increase the conductivity of that signal coming down the SA node, the AV node. It's going to make it go quicker. Those are all effects to the heart. Beta 1. Beta 2, how many lungs do you have? 2 lungs, okay. You're going to get that bronchial dilation that's so needed in those allergic reactions, right? Anaphylactic reaction. In anaphylactic reaction, we get what? Vasodilation. Well, that beta, that's we're going to get vasoconstriction, which is great, right? But then we're going to get that smooth muscle dilation in the bronchioles. And that's what we get from beta 2. All right, then we have sympathomimics, and it mimics the effects of the sympathetic nervous system, what we just talked about. And then sympatholytics, That's going to be the opposite. It's going to inhibit sympathetic nervous system. And those also known as anti-adrenics. Antagonists, drugs that counteract the action of something. And then agonists, that's going to be a drug that binds to a receptor. It's going to cause a response. How about beta blocker? Beta blockers are used to control blood pressure in some patients and heart rhythm disturbances in others. All right, so we have beta 2 selective drugs. I'm just getting caught up with some notes real quick. And we just said what beta 2 does, right? Beta 2, two lungs, selective drug that causes bronchial dilation with little effects to the heart, because we're going to use a beta 2. We're not going to use a beta 1. Oh. Then we have the parasympathomimetics and drugs affecting the parasympathetic nervous system, also called chlorogenic medications. They're called that because they stimulate the chlorogenic receptors to which acetylcholine normally binds. Anti-chlorogenic drugs act to prevent activation of the receptors by binding. So they're going to bind that receptor so it can't receive. If you have excessive chlorogenics are present, the patient may exhibit the sludge. Right, so sludge, salivation, sweating, lacrimation, urination, defecation, drooling, diarrhea. G is gastrointestinal upset and cramps. E is emesis. And then M is muscle twitching. They get exposed, like you'll see this if someone gets exposed to certain types of fertilizers, insecticides, stuff like that. So atropine is one of the most commonly used parasympatholytics. And what we do there is if we have somebody who has a heart rate in, the low 30s and their blood pressure's tanking. Do I want sympathetic nervous system response or do I want parasympathetic nervous system response? Well, I want sympathetic. I definitely don't want parasympathetic because that's going to make it, that's what's hurting me right now. I'm too slow. So I'm going to give them this atropine that's going to block those receptors so that acetylcholine and all that, they can't be playing a game anymore. And that's going to increase my heart rate. We have analgesics, and that's a pain reducer. Then we have opioid agonist. Okay, and that's derived from the opium plant. It's a CNS depressant. Fentanyl, it's a popular opioid agonist. It's rapid acting, it's very potent, and relatively short duration of action. And so it's really good for your trauma patients. It doesn't affect their blood pressure as much. And we have a non-opioid, I feel like I'm having a stroke. Non-opioid agonist. Right, and so affects the production of prostaglandins And so you have your aspirin here, your non-steroid anti-inflammatory drugs. And anticonvulsants, we already should know these sort of from being out in the field. And they believe they work by decreasing the cell's ability to depolarize. And stimulants, depressants. I'm not going to hit every one of these because these are not concepts really, they're just definitions. Let me look at my notes. So let's talk about mechanisms of action for these drugs. So we want a therapeutic effect, which means that we want to reach the appropriate concentration at the site of action. Now, the site of action is important because we have to know how we're going to get rid of this drug too, right? And so these drugs are either going to affect organs or tissues or cells. And so when we're talking about therapeutic effects, we need to make sure we have the appropriate dose, and it has time to the time it takes to travel to its point of action. Okay, so the effects of the drug, it can be local effect or systemic or both local and systemic. The local effect is a direct application of dose to a tissue. All right, so local. So if I took some Benadryl cream and I rubbed it on my skin because I'm having some type of allergy, my skin's been itching, that's an example of a local effect. Now, an example of a systemic effect would be after the drug's been absorbed by the body by any route, okay, and then it's just distributed by the bloodstream. Usually systemic involves more than one organ, but the response of one organ may predominate, okay? So, and if you look at it like this, if you're moving the drug through the bloodstream, then you're probably needing more than one organ to help you do that. But if it's for pain control or whatever, then it's only affecting one certain organ's pain receptors, right? And so that's what they're talking about. And then we got to look at, when we talk about the action part, the mechanism, right? Because the drug is going to bind to some type of receptor site. Okay, that's normally how it works. A drug can actually change the physical properties of a cell. Usually osmotic balance is normally how it does, but it can actually change the physical property of the cells. Now, it can combine with a chemical, all right, and it can go from, you have a bad chemical in your body, and we may give a drug that's going to change all of that, and you go from a problem to a non-problem. The action may be to alter a normal metabolic pathway, meaning the growth of a certain cell, like cancer drugs. We're going to just, change a metabolic type pathway. So, but the relationship between medication and response is usually the amount of med that's given and the response it causes. Now, we got to talk about the termination of action. We need to talk about the amount of time after the concentration level falls below the minimum level to the time it's eliminated from the body. And that's the definition of termination of action. Because the drug will terminate. Okay, it's going to terminate. After it's metabolized, it's going to start, getting out of the system. Therapeutic index. Okay, that's the ratio of the drug's lethal dose for 50% of the population. All right, and then its effects on, its effective dose for another 50% of population. That kind of gives an indication of the medication and the margin of safety. That's what they're talking about there. Another definition that you need to understand is called the biologic half-life. And that's the time it takes the body to eliminate one half of the drug. And so we use Narcan. Narcan, it usually takes about 45 minutes. Another definition, therapeutic threshold, is the minimum concentration required to produce the desired response. So you could have a concentration lower than the therapeutic threshold that will not induce a clinical response, but a concentration higher than the therapeutic threshold may be detrimental. But the goal here is to give the minimum concentration of a drug that will produce the desired effect. I'm just looking at some notes real quick. Remember what when we're talking about toxicity of a substance, it's of that the substance poses a health hazard. Remember though, when we have an unpredictable response, so an unpredictable response would be an allergic reaction. And remember hypersensitivity, after a person becomes sensitized, subsequent response results. So you got to worry about if they've already had an anaphylactic reaction to penicillin, we got to make sure we don't give them any more penicillin. Also, one other thing too, when we're talking about the drug, and its half-life and all of that, is how it, when it's working its way out. If certain drugs sometimes affect the cell and the receptors, like beta blockers, sometimes the only way to get rid of that is for the cell to regenerate, meaning the cell dies, a new cell comes back. And so, that's another way for the body. You might have to wait a while. That's what I'm trying to say. Sometimes it takes a while. All right, guys, I think that's all I have for this chapter. Let me fly through this PowerPoint here just to make sure that there's nothing else This is important. Now, you're going to need to know this. Use the 10 rights of medication administration: right patient, right medication, right dose, right route, right time, right documentation and reporting, right assessment, right to refuse, right evaluation, right patient education. Memorize that. Registry is going to be big on reducing medication errors. So use a current reliable medication. Technical errors can be avoided by having a partner confirm the volume in a syringe. What I do is, so I'm going to give this lady some Benadryl. She's going to get 50 milligrams of Benadryl. It comes in 1 milliliter. I'm going to show my partner the vial. I got Benadryl. there's 50 milligrams of 1 ml. Got my syringe. I'm going to go in. I'm going to draw it up. Then before I give it, I'm going to show them I've got 50 milligrams of Benadryl and 1 milliliter. I'm going to administer. And it's just good to talk it out. And it's good because medication sometimes will look similar in certain vials. And so you want to make sure that you do indeed have the right medication. Even though you've nailed it here, you said, yeah, it's 50 milligrams. I know I'm giving 50 milligrams of Benadryl, 1 ml. But say you accidentally picked up, Epi, which in her case wouldn't hurt her. But maybe you pick up, something else, lidocaine or something that wasn't going to help at all. And so you may be able to avoid that medication error. That's it. All right, guys, enjoyed the lecture. I look forward to seeing you guys soon. I'll be throwing this up on YouTube and throwing out the rest of them as I get them done. So have a great week. Study hard. We'll see you soon.